Hi, caregivers. I'm Donna Jackson, the Adult Caregivers Coach, and we are back with what I think is going to be a really insightful and really helpful segment today. Today, our segment is entitled To Serve with Love, Advice from a Urologist for the Men We Care For. Today we have Dr. Christopher Morrison. Hi, Dr. Morrison.
Hi, Donna. How are you?
Doing well. Thank you so much for joining us today. You know, on our podcast, we bring in experts to speak to the caregiving community, caregivers of elderly loved ones, about everything and anything they may encounter during their caregiving journey. And so today, Dr. Morrison, introduce yourselves to our community, and then we're going to begin our discussion.
Sounds great. So I'm Dr. Morrison. I'm a urologist with Kaiser Permanente, based in the Mid-Atlantic region, primarily based in DC, but also see patients in Southern Maryland.
Excellent. You know, one of the things, this is going to be a lot of myth busting discussion that we're going to have. And I want to make sure that we are addressing as many, pieces of information that's not readily known out there, especially for caregivers who might be women and or caregivers who really have never had an experience with a urologist. So one of the first things I would like to jump into here is, when would a man know that they might need to go to a urologist? And how does that look depending on if they regularly go to see their primary physician or not?
Yeah, a great question. So probably two of the most common reasons that we see men come to urology will be either due to symptoms that they've developed, whether it's urinary symptoms, sexual dysfunction symptoms, something that's bothered them in their life where they've gone to their primary care doctor and asked for a referral or sought out a urologist on their own. Mm-hmm. But the other is any kind of prostate cancer screening. That's one of our biggest referrals. And that often, those patients won't have any symptoms at all. And it's detected on blood tests done by their primary care doctors as part of annual health maintenance screening.
Wow, that is so interesting, because I was actually going to ask you, what types of symptoms might they be experiencing that would make them even ask about, things. So literally you're saying they could have no symptoms. So is it an age-related kind of discussion that their doctor might have with them?
Yeah. So prostate cancer is a cancer that develops, primarily as men get older. Again, I'll see many patients that come in with an elevated PSA, which is the screening blood test. And they'll say, well, doc, I'm not having any symptoms at all. Like, I can't have prostate cancer. And I tell them that's a good thing, right? If you have symptoms from prostate cancer, it's usually at a point where it's not curable. Okay. And so the goal is trying to identify men who may have prostate cancer based off of screening tests.
Wow, that is so good. I don't know how many folks know that. One of the other things that, I wanted to talk about is the juxtaposition between just men in general and how they take care of themselves in terms of going to regular doctor's visits and things like that. So I'm going to just throw everybody into the pot here. I'm going to throw in, young men, middle-aged men, older men, single men, married men, men in the Black community, and men in the white population community. Do you see any trends that kind of, our eyebrow raisers in terms of just across the spectrum, the behaviors of these guys?
Yeah, I mean, I would say in general, young men who are pretty healthy or feel like they're pretty healthy probably don't go and see their primary care doctor or seek medical, screening as much as men that are older. And I think that's, just when you're feeling great, the last thing that's on your mind is going and seeing a doctor, even if it would be for kind of routine screening. I think there is, some assumption that men maybe just don't go to the doctor as much. But I would say that is actually changing. It's interesting. I see a lot of men who are coming in, and when they're seeing me, they're saying, well, I talked to another guy about what's going on in his medical, his medical condition, or what's going on with his prostate or sexual function. And I'm finding that older men are getting much more comfortable talking with each other about what's going on in their lives. And so, yes, I think historically there's been, I'll see patients when I ask their family history, and they'll say, oh, well, my dad had something, but we didn't talk about it. It was something that we never talked about. So I don't know what he had, but it was something, related to the prostate or something like that. But I would say that I'm seeing quite a bit of change in that regard, which is great.
That really is a good trend. So, as we open, we focus on the caregiver, right? So a lot of times the caregivers are the women in the family, right? So what are some ways that we can kind of guide these caregivers into how they approach and address maybe an elderly man that they're caring for, their husband, an uncle, a grandfather, a father, who may or may not have had urological issues, but just even the normal aging? What are some things that they can look for or help to identify as their loved one's age, and they're looking after them?
Yeah, I think for men, one of the most common things that men will develop as they're getting older are urinary symptoms related to an enlarged prostate. All right. And for most men, that's a very gradual progression over time as their urinary symptoms are kind of worsening and worsening. And so they may not necessarily see it as a huge problem, right? But there can be signs that a caregiver might be able to notice that would suggest that they're having issues related to their prostate, right? If they're hearing their, father or grandfather or uncle getting up 3-4 times at night to urinate, that could be a sign of a prostate issue. Or if you're, driving home from running some errands, and then, the father or uncle suddenly is like, we have got to stop the car right now. I got to get to the bathroom. I can't hold it. Right. Mm-hmm. Those are all symptoms of enlarged prostate. And so that's where I think it would open a door to be like, well, do you like getting up 3 or 4 times at night to go to the bathroom? Would you want more time to make it to the bathroom instead of having to run there? And maybe that would spark their, interest in seeing a urologist.
Yeah. Interesting. As you were speaking, I was thinking, and maybe a lot of other people think, that's just natural aging. Like, that's just what happens. And so they don't even get alarmed about it because, to your point, they may have seen that in their father or grandfather and nobody was talking about it. So it's just like, oh man, well, this is now my time to do this. Not even understanding that that doesn't have to be your experience. Wow.
Correct. Nice. And even though, a lot of people think urologists take care of, mostly men, a good portion, we take care of men, but we also see women. And I will see the same thing with women where, they start developing incontinence as they're getting older, and they just think, I just have to live with this. This is what my mom did. This is what my grandmother did, and I just have to live with it. And that's not always the case. So it's not just limited to men. Women can also have similar symptoms.
Okay. Well, that just busted a myth for me, because I had no idea, none, that women went to urologists. Oh, wow. I thought that was pretty much handled just by your
Gynecologist.
GYN.
Yeah. No, we, a lot of folks think urologists are kind of men's health and, sexual function and prostate issues, but, we treat the whole gamut of urologic conditions from, kidney cancer, kidney stones, which, don't discriminate based off of gender, bladder cancer, urinary symptoms in women and men. Yes, most of the sexual, function is going to be handled by a GYN for women. But the urinary symptoms, that's in our wheelhouse.
Interesting. Okay. I'm thinking even about the psychological change that happens, or shift that happens when this comes into play. So because now you're talking about, kidney stones and different things like that, you see a wide age range of folks. Is that correct?
Yes, absolutely. From, as in my practice as a urologist, I see only adults. We have in our practice urologists who see pediatric patients, but urology encompasses the entire lifespan, from, newborns to end of life care. Yeah.
Yeah. Wow. So in addressing what's going on, the changes in just mainly older folks, right, and the caregivers who are helping them out, what would you say is maybe the most challenging discussion that needs to happen, whether it's between you and that patient, or even ongoing in terms of the caregiver trying to address and, even encourage or, provide the level of support and care that their specific loved one needs, like in terms of wearing Depends and or using those tools. Even for a woman, I see the commercials where there's this incontinence tool, and it sits outside of the body, and it absorbs moisture and things like that throughout the night. Are these things, is there a way that we can have these conversations without robbing them of their dignity and things like that?
Yeah, I think, for a lot of patients that have, urinary incontinence or things like that, there are things that we can do, and we can try to get patients better, right? Where they're not needing the bends or they're not needing to wear pads. But with that said, there are times where, there is no treatment that's going to necessarily fix their problem completely, right? And so I think just trying to be open when communicating with patients, and it's not as a caregiver, I would encourage you not to get frustrated when they have an accident in the bed, right? Because that's going to obviously upset them and make them feel worse. I'm sure they already feel bad when they've had an accident. But I think just trying to come up with strategies on how best to manage the leakage or incontinence is great. And what you were referring to is something called PureWick, which is a suction external canister that basically suctions urine, and they actually make that for men and women. The main limitation is it's at least right now, is it's often not covered by insurance. And so it can be quite expensive, but I have had some patients that have used it and have just, it's been a game changer for their quality of life.
Mm-hmm. Wow. Well, it's so good that these kind of solutions are out there. Hopefully they can get some portion of it can at some point get paid for by insurance, because yeah, I know they're super expensive. So are there any lifestyles and or medications that can contribute to this, incontinence or even the prostate enlarging?
Yeah. So prostate enlargement is largely out of a man's control, right? It can be genetic, but really it's related to age and genetics. The prostate's just going to enlarge. There are medications that can limit, growth of the prostate. And then of course there's surgeries that can be done when there's an overgrowth. But certainly there are things in a man or woman's life that can worsen their urinary symptoms. Okay. So from a dietary perspective, caffeine, alcohol, spicy foods, sodas, all those things are bladder irritants. And so if you already have a sensitive bladder and you're taking in those some of those chemicals that irritate the bladder more, that can worsen urgency or incontinence. Okay. Medical conditions, absolutely. Biggest one that we'll see is diabetes. Particularly uncontrolled diabetes. What that leads to is a lot of sugar getting dumped through the kidneys into the urine, and that not only irritates the bladder, but it increases how much urine is being made, and so that can certainly contribute to urinary symptoms. And then last, and this is again a little bit out of folks' control, but as patients get older, believe it or not, their kidneys aren't as good at holding on to urine overnight. So for younger patients, your kidneys are basically trying to hold on to urine overnight. And then during the daytime, they were getting a signal to basically release urine. And so there's this natural fluctuation between the day and night telling your kidneys to hold on to urine or release urine. But as patients get older, that fluctuation diminishes. And so the kidneys tend to be making more urine at night. And so that is something that we'll see that a lot of patients struggle with, but trying to limit fluids before bedtime can help with that.
That's so interesting, the last piece. And I mean, all of it is really informative. The last piece, I wanted to stop there. So tell me if you're going to bust this myth for us. During COVID, I heard people talking about, their bladder muscles and everything were weakened because they were at home. They had quick access to the bathroom. They didn't have to hold themselves like if they were at work and it's like, oh, let me finish this one document or this one email before I go to the restroom. And so this whole buildup of muscle strength, the bladder and all that stuff had diminished. Is that a myth?
I have not seen any, as far as I know, yes. I have not seen any evidence that, being, stuck at home and close to a bathroom has significantly changed urinary habits. Okay. When, a lot of people, when they talk about kind of weakening of the bladder, what they're actually referring to is not that the bladder muscle has become weaker. It's that the ability to hold in the urine. So actually the sphincter muscle has become weaker. Okay. And that can happen as patients get older. Their muscles naturally tend to get smaller as we age and weaken. But another thing that can contribute to worsening leakage or that type of leakage, which we call stress incontinence. That's basically when there's pressure on the bladder. And if the sphincter muscle isn't strong enough to hold in the urine, the urine can leak out, is the increasing obesity epidemic, right? So patients are unfortunately getting larger and larger, and the bladder sits at the bottom of the pelvis. So all that fat and belly that's sitting on top of the bladder is constantly pushing down on it. And I think, during COVID, again, I don't have the data for this, but I believe there has been, patients tended to put on a little bit more weight because they weren't as active, right? They were at home, working from home, snacking, things like that. So I could see how that could potentially have increased to urinary leakage.
Wow. Okay. Yeah. Just a little side note there. I want to circle back to the whole idea of men not wanting to go to their primary physician and have this PSA test done. So again, I don't know. What I've heard. So if you can put it in context for us, that would be helpful. So when, all the jokes that the doctor, you're getting ready to leave, the man is in there, he's getting ready to get dressed and go out. And then all of a sudden you hear the doctor pop on the gloves, pop, pop. So this is a big joke, right? But that has been something where guys are like, yeah, I'm not going to the doctor. I'm not having some guy, do this to me. It's all these things. Can we just kind of just get this out in the open? Like, what is that? What, like, even psychologically, what's happening with men who are resisting having this check? Because this is the methodology that's used to check you. And why are people resistant to this?
Yeah. So, what you're referring to is what we call a digital rectal exam, which is where either a primary care doctor or a urologist will basically feel the prostate. And that's by inserting a finger into the rectum. And we're basically feeling for anything that feels suspicious for cancer. That's always our biggest concern, but also to try to get an idea of just how big the prostate is, particularly if they're complaining of urinary symptoms. Okay. I think from a psychological perspective, it's an invasive exam, right? And I think for women, growing up going to a gynecologist, right, as in their early, or teens, 20s, they're used to that exam. It's just kind of built into the culture, I would say, of being an adolescent and, maturing woman. For men, they don't really have that same kind of invasive exam that's done earlier on in life. And then when they get into their 50s, suddenly, they're being told that they need to have a finger put in their rectum. So I think it can be, a little bit of a new experience. One thing I will add is the American Urologic Association has altered their guidelines more recently, where the main test that we want to use for screening for prostate cancer is the PSA test. The digital rectal exam, they used to always go together, but the American Urologic Association has kind of loosened their recommendation on doing a digital rectal exam on all men, because the likelihood of us detecting something that we wouldn't have detected with a PSA test is relatively low. And so hopefully that will make men a little bit less afraid about going to a urologist if they're not going to be subjected to a digital rectal exam every time.
Wow. No, that is really helpful. And I'm glad that things are advancing. I often joke, and I'm sure a lot of women will, that if the screenings that women had to go through, particularly the mammogram, if body parts were manipulated on men the way they are on women in that mammogram, we would have had something other developed for us. I mean, if that was for men, a man would have figured out like 1,000 years ago that's not how we're going to test. We're not going to squash you to death to test anything. So that is always, every year when I go, I'm like, you know what? This is crazy. Did a man think of this solution? Anyway, in terms of that, the caregiver, and let's just say, and if this is not something that you've seen, that's okay. But I would be remiss not to ask this. What if the caregiver is, you know, the daughter, and it's her father, her grandfather. And she now has to administer, you know, bathing and just all kinds of things that are very invasive, private, and complex. These are the complex relationships. Have you seen or any suggestions on even the mindset that they might want to adopt before they kind of enter into that space with them, so that it makes it okay and it doesn't make it weird and, you know, taboo and those types of things?
Yeah, I mean, I think you can almost, as a caregiver, think of yourself as a medical professional at that point, right? So, you know, this is, you know, yes, it's your loved one, but you're not, you're approaching your loved one more as kind of a patient in that situation. And it's the same thing that we do as doctors, right? Especially as urologists, where we're doing, you know, genital exams and all sorts of invasive exams with patients. It's a physician patient, you know, interaction. And I think trying to have that mindset as a caregiver is what I would recommend.
Yeah. And so conversely, how could we help the caregiver when they are able to adapt or adopt that mindset, but that elderly man is not, and he's pushing back?
Yeah, I mean, that's really, you know, gets into a harder position, right? Because you want to respect the dignity and the autonomy of, you know, your loved one as a caregiver. But you also have to balance that with making sure that they are, you know, having the necessary, you know, hygiene and care that's needed, right? And I think with a lot of things in life, it really comes down to just trying to communicate things in as, you know, loving as a way possible. Trying, you know, if there are issues, trying to engage with, you know, their primary care doctor to help give that additional medical reasoning to the patient as to why they need to let their caregiver be involved in their day-to-day life.
Yeah.
Care.
Yeah. No, that it is tough. And that's why we do these. It's just so tough. It's a tough season of life for both the aging, you know, loved one and that caregiver. One of the things we also try to tackle here, and this might just be a comment, but if you want to jump in and add to it, please do. You know, one of the things that is almost devastating, I can say, as a caregiver who, for whatever reasons, the way things have played out in the life of the family, that the person who needs the care may have been a person who abused that caregiver in an earlier part of life. Dr. Morrison, my clients and the caregivers that I coach, they are facing all types of super complex relationships, you know, where they might have been adopted and now their biological parent needs care. It's a lot that people are dealing with. And so, you know, would you suggest, at least even as a doctor, that these types of complex relationships, that caregiver get, you know, coaching or counseling before entering into that? Because if we're human, there may be the tendency for retribution at this point. Like I've been waiting for this moment, which is unfortunate, but it's real.
Yeah, I think, you know, for someone that's new to caregiving, I think getting as much coaching, whether formally or talking to, you know, other friends or family members that have been caregivers is absolutely important. You know, I think sometimes all the focus is put on the person receiving the care and not necessarily the person giving the care. And I'll tell you, I can't imagine a caregiver being able to give good care if they are not also taking care of themselves, right? And it's the same thing that we look at as doctors. Doctors that aren't taking good care of themselves cannot take good care of patients, right? And so if a caregiver is experiencing things mentally or physically that is limiting their ability to take care of themselves, they should really be asking, am I the right person to be taking care of my loved one?
Oh my gosh. Yeah. And again, I agree with you 100%. And caregivers, please, if the healthier you are, like Dr. Morrison said, and that's not just physically healthy, but emotionally healthy, mentally healthy, spiritually healthy, the healthier we are as caregivers, the better we're able to navigate those really difficult, scenarios that are going to come up during this time of life, caring for our elderly loved ones. Be sure to do that self-check. Am I healthy enough to do this? And sometimes you're the only one, you're it. Like you're the only one in the family who can do it. Financially, there's not a lot of resources available, and you find yourself, you're the one. But what you don't want to do is destroy your soul in the process of trying to care for your loved one. And that can manifest in many different ways, particularly in a situation like I've described, where you might have been on the receiving end of the person you're caring for, trauma, abuse, neglect, anything. And now you're in the driver's seat. What will you do? So we're gonna make a sharp pivot right here to something that I've been hearing more and more about. And again, you just hear little snippets of conversations and you have no idea what the full context is. But is there something where younger men are experiencing erectile dysfunction at greater rates now? I'm just hearing this more and more, and low testosterone, and they're like panicked. You can just hear I'm talking about men in their late 30s and 40s. It's just like alarming how many are experiencing this, and potentially what can be the cause of this.
Yeah. So when we talk about erections, when I see a gentleman, doesn't matter what age, and they're coming in with issues with erections, this is what I tell them, right? So you need two things to get an erection, and it's basically the hardware. Okay, that's going to be the blood flow, the nerves that control the erection, blood flow, nerves, erectile tissue, and then you have the software. Okay. And that's everything that's going on up in the mind. Okay. And the two have to be synced in order to get an erection. And so the example I use, it's an extreme example, but if you could have absolutely perfect hardware, but if you're out in the wild getting chased by a bear, no matter how hard you try, you will not be able to get an erection. It's physically impossible because the software and the hardware will not line up. Okay. And so, when I see young guys that are coming in, almost always their hardware is perfect, right? They don't have the medical conditions like diabetes and high blood pressure and high cholesterol that all over time starts to affect the erections, right? More often than not, it's something going on psychologically with them. And it can be a vicious cycle, right? It takes one time with a partner losing that erection, that the next time that they are with that partner or a new partner, they're thinking about, am I going to be able to maintain the erection? Am I going to lose it? What's my partner going to say? How it's all starts cycling in there, and it starts messing with the software, and the two do not line up. So I think, for young guys, if they're coming in with erectile dysfunction, I'm often needing to probe what might be going on psychologically. You brought up testosterone. A lot of folks don't know this, but obesity also can start to have an effect on testosterone. And so as the younger generations are having increased rates of obesity, that can cause their testosterone levels to go down because there's an enzyme that's in fat cells that takes the testosterone, which is what men need and want, and actually changes it into estrogen. And so, if I see an overweight man coming in with low testosterone, the answer is not, oh, here's some testosterone. No, it's things like weight loss and diet and exercise as kind of the first step.
Wow, that is, woo. All right, guys, we're getting some really good information here. Dr. Morrison, before we shift from this topic, potentially, is there an age limit to a man achieving an erection as he ages?
No.
All right, guys, that's great news.
I've seen men in their 80s and 90s still going strong without needing any assistance, whether it's Viagra, Cialis, or more invasive treatments. And it will surprise me, right? Most men, once they get into their 60s, 70s, 80s, they will notice that their erections are not the same. And a lot of that is related to how you've taken care of your own health over the past several decades of your life. And so if you're not going to the doctor and, getting screened for high blood pressure or high cholesterol or diabetes, and you're having those underlying conditions that are not being treated, what will happen is you will start to develop some of the consequences of that throughout your body, but that can also affect sexual function. So another plug to go and make sure you're checking in with your primary care doctor, even if you're in your 20s, 30s, making sure everything's perfectly healthy. There
you are. And ladies, you're welcome for me asking that question for you. A lot of our aging men, fathers, grandfathers, uncles, to your point, they're still very vibrant, and they're still, they're very active because they were active all their lives, and that's just a part of it, which is good. I still see quite a few baby boomers who are really active in the pickleball and just all the things that they're still doing. And they're living independently in these senior communities. So how often are you seeing these very active elderly men who are literally coming in because they have STDs, because they're really active and they're really buzzing around in those communities, and there are a lot more women in those communities, maybe who are widowed or what have you, and the community, they are having a ball in this community. What would you say to caregivers who are not necessarily caring for their males on a 24/7 kind of a schedule, but checking in with dad or checking in with granddad once a week, twice a month, those types of things? What are some things that, and now that we're not even that close, not bathing them and doing all those types of things, how are we going to have these conversations about, okay, guys, yeah, just because you're, 78 doesn't make you immune to, these sexually transmitted diseases and infections. How do we have that conversation as a caregiver?
Yeah, it's like a role reversal from when the parents giving the birds and the bees discussion to the high schooler, right? So, in terms of sexually transmitted diseases, actually, as a urologist, I don't see a ton of that because most of that is managed by their primary care doctors.
Okay.
I think, but regardless, I think, again, good communication, making sure that they're seeing their doctor regularly, and if they're developing any symptoms of STDs, and then I think, it can be hard as the child, right, or the caregiver trying to lecture a parent or whatnot as to sexual health and things like that. And I would say it's probably going to be pretty variable as to which caregivers are going to be comfortable with that discussion, which ones aren't. I have heard of, retirement communities where, or nursing homes where there can be really, not nursing homes, assisted living facilities where there can be high rates of STDs. I think just trying to be as minimally judgmental as possible. I mean, just because you're at an advanced age and needing to have some assistance where you live doesn't mean that you're dead yet. So, trying to be supportive and understanding, I think, is always good.
Oh my gosh. Yes. And, there's, well, not always, but frequently there is like the rooster in the hen house. And he is just, he's the virile. He's still virile. And I laugh about it. It's not really funny, but it's one of those things that as younger people, you just don't think is happening. You're like, what? Are you serious? And my goodness, there are all types of things going on at these senior centers and living facilities. And it's kind of refreshing, though, at the same time. I mean, it can get to an extreme. I get that, too. But at the same time, it's kind of refreshing to know that, yeah, they're not dead. And that they can be having, still having pleasure in their lives in a way that they may not have thought. So that's always great. So just trying to think of, I know there's one other thing that I would like for us to cover before we wrap. And that is jumping back to the, after, your loved one has gone through the PSA testing, and let's just say that there is cancer. Let's just say that there is prostate cancer there. And I have loved ones in my family and friends, dear friends, who have gone down this path and were relatively healthy, lived healthy, relatively healthy lifestyles, active, all those things. And when they found out they had an elevated PSA, and one person in particular I'm thinking of, they were at stage 3 or stage 4. No, not stage 3, stage 2 or stage 3. And it was just so shocking to them. And when he just told me about it, he didn't fit the profile because, again, very active all of his life and relatively healthy. And so can you just, if you can, just walk us through what that looks like, and when we talk about the different stages, what that actually means? Because as a layperson, until he explained to me what the stages meant, I was completely wrong in my mind about what I thought it meant.
Yeah. So with prostate cancer staging, most prostate cancers, we are, especially if it's getting detected with an elevated PSA, we're catching it in one of the first 3 stages. And that's usually referring to just how aggressive the cancer cells are, looking underneath the microscope, how much of the prostate is involved. Stage 4 prostate cancer, that's when it's spread. At that point, curing prostate cancer is almost impossible. And so our goal is always to try to catch it early. And for many men where we are able to catch it early, there are some treatments that can cure them. And those two treatments are usually surgery to remove the prostate or radiation to the prostate. Unique from a lot of other cancers is that the treatments that are involved for treating prostate cancer, whether it's surgery or whether it's radiation, can have a lot of functional changes for a man. And that's probably the most intimidating thing about getting the treatment, is how it's going to affect their sexual function, how it's going to affect their urinary function, which can be different than other cancers where maybe you're just removing a kidney, right? Your kidney function may change a little bit, but your day-to-day life, you're not going to really notice too much of a difference. That's different with prostate cancer. Historically, decades ago, we as urologists treated prostate cancer as all the same, whether it was, a low-grade prostate cancer or a high-grade prostate cancer, that everyone kind of got treatment. And we realized that we were over-treating prostate cancer because prostate cancer is a very slow-growing cancer. There's many men that will be diagnosed with prostate cancer who will never die of prostate cancer. And we can safely watch a large percentage of those patients and maintain their overall sexual and urinary function without, having to do invasive treatments. But if you are in that, that more aggressive group of patients with more aggressive prostate cancer, then yes, treatment is generally what we would recommend, and we kind of help men navigate the sexual and urinary side effects that may develop from that treatment.
Mm-hmm. Yes, and thank you for that. And is it true that a part of how you guys determine, how doctors determine the staging is that you start with where the initial site was, and however many additional places where the cancer has kind of metastasized, like gone into these other areas. Is that how you do the stage 1, 2, 3, and 4?
Correct. It's based on how aggressive the cancer cells are and how much of the prostate's involved. And then, yes, we look for any signs of prostate cancer spreading to lymph nodes, okay? Whether they're local lymph nodes or widespread lymph nodes. And then kind of, again, stage 4 is when it starts spreading, to other organs, bones, things like that. So it's we kind of, for someone who we're concerned about prostate cancer, the workup that we do is start by doing a biopsy. Sometimes we'll do an MRI ahead of time, but doing a biopsy, getting a tissue diagnosis that shows prostate cancer. And then if there's concern that this is a more aggressive prostate cancer, we do imaging studies, basically looking for any signs of prostate cancer spread. And if there isn't any, that's where we're looking at doing hopefully definitive and curative treatment for the prostate cancer.
And if the situation is that the type of prostate cancer and levels are curable, can it recur once it's cured?
Yes, it certainly can. And so for men who have been treated for prostate cancer, we will do PSA monitoring typically the rest of their life. And because the PSA is such a sensitive test, if there is any recurrence of the prostate cancer, it's going to show first on that PSA test. So that's how we manage and monitor long term. But again, many men, if they develop prostate cancer, we're able to cure them. Even if they develop recurrence, there's additional treatments that can be done. And our goal ultimately as urologists is, even if they have recurrent prostate cancer, that we're allowing them to live a long life without the prostate cancer being the ultimate cause of their death.
Mm-hmm. Yeah, and that's great to hear, and actually good to know. It's not a death sentence, and people can live decades with it, and ultimately passed from something other than that. So thank you for that, Dr. Morrison. Well, caregivers, I hope this has been informative. We try to bring a little levity as well to the topic, but this was one I really wanted to get out in front of you. And so I'm just so thankful that Dr. Morrison was gracious enough to come on and talk with us today and help educate us in this space. So Dr. Morrison, let our listeners know if there's anything you're working on in your practice or even beyond your practice that you want to share, or anything that's going on with the organization that you work for that you like to share, anything. And we'll drop it in the chat below the audio and the video. But if there's anything, you can share it now. Otherwise, we can just drop ways for people to contact you if that's what you'd like. But we always like to give our guests an opportunity to share what they're doing.
Yeah, thank you. I mean, as a urologist at Kaiser Permanente, I get the privilege of taking care of a great patient population, but it is limited to the Kaiser Permanente population. So a lot of people don't know that, but unless you have Kaiser Permanente, I'm not able to see you. So it's a great organization. We really look at, trying to take care of patients at a population level, preventative medicine. And I'm proud to be a Permanente physician. So thank you.
Excellent. Well, thank you so much.
Thank you, Donna.